Hello, this is Ganesan Abu, and welcome to part 2 of the series on sepsis. In this section, we will look at antibiotics in sepsis, taking a stewardship approach to the problem. This is an alarming slide that demonstrates the global impact of antimicrobial resistance. Take a moment to consider that last year, 700,000 people died worldwide because their bacterial infection was resistant to every known antibiotic. That's 700,000 people, and we simply did not have a cure. Now, as primary care providers, we may not acknowledge that we are part of the problem. Even so, I hope that we can at least pledge to own the solution and take an active role in carefully considering why and how we prescribe antibiotics. Secondly, I wanted to share the framework that I use when considering antibiotics. I chose sepsis as an example, but the same framework can be applied to almost any infection. So, why did I choose sepsis? Well, sepsis presents a unique clinical dilemma in terms of antimicrobial stewardship. Firstly, there is no diagnostic test for sepsis, nor is there a point of care test to confirm a bacterial versus fungal or viral infection. Secondly, we are under time pressure to start antibiotics as soon as possible. These factors may sway us to prescribe antibiotics in ways that actually promote antimicrobial resistance. So, my approach is based on what I call the 5D approach. And we consider the indication for the use of antibiotics, the drug choice, dosage, duration, and de escalation. And I'm going to briefly outline this approach in terms of these 5 criteria. We know that sepsis is predicated on infection and that rapid reduction of the antimicrobial load is warranted. And we need to do this to prevent injury caused by microbial activity and toxin production, as well as to prevent or ameliorate the harmful host response to infection. Despite the difference in timing to first antibiotic in these studies, there was no difference in mortality. And a closer look would reveal that the time to first antibiotics varied from a low of 70 minutes in one of the more recent trials to almost 6 hours in the Rivers trial of the early 2000s. This study, that was done in Winnipeg by Anand Kumar and Dan Roberts, showed that for every hour delay, there was a 7% increase in mortality. However, one of the primary criticisms of the study has been that it has never been replicated. Stronger evidence of increased mortality after each hour of hypotension in sepsis is available or indicated by this study. And this is somewhat easier to appreciate because it's a little easier to figure out time zero for an event such as hypotension rather than figure out when time zero was for the onset of sepsis. Now, I am in no way encouraging you to delay antibiotics, but I am suggesting that you have enough time to carefully consider optimal antibiotic use with a view to limiting antimicrobial resistance. When choosing a drug, choosing the correct drug the first time is crucial. Getting it right still has a high mortality of about 28%, but getting it wrong doubles that number. We need to use broad spectrum drugs, and by that we mean one that covers many different types of organisms. So, gram positives, gram negatives, anaerobes. The second thing is that we need to rely on combination therapy. And by this we mean that we choose two drugs from different classes that work against the most likely organism in order to accelerate pathogen clearance. So, for example, in treating sepsis caused by a pneumonia, we may want to consider using a beta lactamase plus a fluoroquinolone. So, how do we go about making a choice of an appropriate antibiotic? Firstly, we have to consider patient factors. Extremes of age pose a problem in terms of choice of antibiotic and resistant organisms. Comorbidities such as renal or hepatic dysfunction may require altering the dose. Host immune status may influence choice. For example, post-splenectomy patients would need cover for encapsulated bacteria such as Haemophilus influenza. Patients on dialysis and residents of personal care homes are more likely to have resistant organism. Knowing the site of an infection may give us important clues. Certain bacteria have a predilection for a specific site. Example, the commonest pathogen in pneumonia would be pneumococcus, making a respiratory quinolone an appropriate choice. Treating meningitis requires good penetration of the blood-brain barrier, and ceftriaxone may suit this purpose. Lastly, one has to consider the most likely organism in that environment. Knowing the prevalence of MRSA in the facility may determine what prophylactic antibiotic to use perioperatively. Similarly, we would avoid prescribing amoxicillin for urosepsis if our antibiogram showed an 80% rate of resistance. So, how do we determine the dosage of an antibiotic? Well, let's consider some of the science behind this first. For an antibiotic to work, it must penetrate the bacterial cell wall and attach to the target receptor in the cytoplasm. Its killing is dependent on two factors. Firstly, the number of receptors it binds to, and this is also known as a concentration effect. And secondly, the time that it remains bound to the receptor, a time-dependent effect. So the interplay of these two lead to what is known as the area under the concentration time curve. Time-dependent antibiotics need to remain above the minimal inhibitory concentration for a significant portion of the dosing interval, at least 60% of the time, and hopefully 100% of the time when treating sepsis. Furthermore, these drugs need to be given as continuous infusions or frequent dosing interval. Therefore, a drug such as piperacillin-tazobactam is given Q6 hourly, and it would be better still if we could give it by an infusion, but this is labor intensive. Concentration dependent killers need a high peak above the minimal inhibitory concentration and depend much less on time. Therefore, if one is using gentamicin, one would choose a once daily bolus dose at the high end of the dosing range. Sepsis is a bit unique in that, apart from these factors, one needs to keep in mind that sepsis has a significant amount of leaky capillaries and increase in the interstitial fluid volume. Furthermore, the fluid that we use in resuscitation also leads to an increased volume of distribution. Apart from this, there's also this phenomenon in sepsis of augmented renal clearance that seems to get rid of the drug quicker. These two factors account for suboptimal dosing, and this results in a low first peak level, ultimately leading to drug failure. The importance of knowing this is that regardless of the mechanism of killing, the very first dose has to be at the high end of the spectrum and given by bolus or rapid infusion. For example, we should start piperacillin-tazobactam at 4.5 grams initially and then continue at 3.375 grams Q6 hourly. How long do we need antibiotics for? Well, there's a balance in the way we think about this. We believe that antibiotics are benign, and we want to continue therapy for as long as it will make sure to guarantee a cure. However, antibiotics are not benign and carry increased risk of antimicrobial resistance, of C. diff infection, and drug toxicity. Although there is no evidence to guide duration of treatment, 7 to 10 days appears to be adequate, even in severe infections. One could consider a prolonged course if there is poor clinical response or a non-drainable focus of infection. Staphylococcal bacteremia or candidemia would also warrant longer treatment. Alternatively, a rapid clinical resolution could prompt shorter course of treatment. Procalcitonin may be used as an objective guide to discontinuing or switching antibiotics. For example, if we look at the blue line, the rapid fall off and low absolute level of procalcitonin at day 6 would suggest that it is safe to stop treatment. The last aspect that I want to consider concerns de-escalation. When we start antibiotics, we use our best judgment and start empiric, broad spectrum antibiotics. Once the culture results are known, we may want to switch to a narrower spectrum that is less likely to lead to resistant gut organisms. We should keep in mind that the culture result is unlikely to change after 48 hours. Therefore, using our clinical judgment, after 48 hours and once the culture result is known, we should assess for every opportunity to de-escalate therapy. To summarize then, the time to antibiotic may be critical, but we do have enough time to think this through. Our initial choice of antibiotic is empiric and should be broad spectrum and combination therapy based on patient factors, the site of infection, and local resistant patterns. Regardless of the killing mechanism, the first dose should be at the high end of the range and given by bolus or rapid infusion. Concentration-dependent drugs need to be dosed frequently or by continuous infusion. Time-dependent drugs require once-daily dosing at the high end of the dosage range. Even for severe infections, 7 to 10 days of intravenous therapy is adequate in most cases. After 48 hours of empiric therapy, and once culture results are known, consider de-escalating to a narrower spectrum antibiotic. Thank you, and I hope that this was useful to your understanding of managing antibiotics in sepsis.